record, and we are going to get started right now. So thank you so much for being here. We have a wonderful group of panelists here. I'm going to go ahead and let each one of them introduce themselves. Just share your name, your hometown, and your specialty interest, and also what rotation you participated in your third year or are currently participating in. So that's the Cleveland Clinic longitudinal clerkship, the Metro longitudinal clerkship, or the traditional core rotation at multiple hospitals. And Sophie Toe, I'll start with you.
Oh, maybe it'll work. Can you guys hear me?
Loud and clear.
Beautiful. Hi, everyone. Nice to meet you. I'm Sophia. I am a third/fourth year. I'm on my research year, actually. So I did the Cleveland Clinic longitudinal program. I'm happy to answer any questions. And I'm here with my dog, well, one of my classmates' dogs. So I hope you guys enjoy that as well.
All right. Thank you. And then I will head over to Dennis Voom next. You hear Dennis?
Mm-hmm.
There you are. Hey, Dennis.
I'm Mr. McKenzie. Yeah, so I'm from Columbus, Ohio. Came up to Cleveland a couple years before starting medical school. I did the traditional, so rotating kind of through Metro, UH, VA, and then currently interested in internal medicine. And then it's my third year, so obviously kind of a
Awesome.
year.
All right. So we have Sophia, we have Dennis, and Henry. Go ahead, Henry.
Hey everybody, I'm Henry. I'm from Akron, Ohio, also a third year like Denny. I'm doing the traditional track. So I've been through Metro, VA, and UH. I wanted to do all three while I was on the track. And then I'm going to be applying in general surgery here in a couple months.
Excellent. Good luck, Henry. That's great. And I see Dominique is here as well, last but certainly not least. Thanks for waiting, Dominique. Go ahead.
Hey everyone, I'm Dom. I'm from Newport News, Virginia. I'm an M4. I did the Cleveland Clinic longitudinal track. I matched at UCSF in general surgery. So yeah, happy to answer any questions.
And congratulations on matching as well. Thank you so much. So I want to start out and kind of address, looks like we have a question coming in the chat. And if anyone has questions, this is kind of pretty informal, truthfully. So if anyone has questions they just want to ask our panelists, go ahead and place them in the chat. And we can kind of do it this way. And I have some questions as well if we need to continue to fill the allotted time. But I see Brian asked, how many people kind of get the Cleveland Clinic route versus how many usually apply for it? I thought it was usually around like 50 or 40 to 50 a year. Do any of you know the answer to that by chance?
I think, unless Dom wants to answer, I think last year, at least when I was in M3, they took 70 of us, if I'm not mistaken.
Oh, wow. Okay.
If I'm not mistaken, yeah. I don't know how many apply though.
Okay. Yeah, I knew it had grown. It's grown quite a bit over the past several years. Can you share a little bit, Sophia? Because I know you're in the Cleveland Clinic longitudinal clerkship, correct? Could you kind of share why you chose that particular method and route to train in terms of the longitudinal experience and kind of what led into that and how the experience was and has been for you?
Absolutely. Well, I really debated a lot between the UH Metro traditional program as well as the longitudinal program. But I ultimately went with the Cleveland Clinic Learner program just because I felt like there was a lot more cohesion with how you transition from rotation to rotation. I also like the fact that it had the same system, so you didn't have to learn a new way of documentation every time you went to a new rotation. And that kind of reduces a lot of the stress at the beginning of the rotation because you don't have to not only not know anything that you're supposed to do, but also learn how the hospital works. As the rotations progress, it's actually easier because now you have a pretty good lay of the land, so you know where to go usually. Also, I really like the fact that we get Fridays off because I knew that I might need a little bit more time to study for my shelves. And I thought that protected time would be very important for me. That being said, I'm not saying that the traditional program does not have protected time. It's just not as built into the actual curriculum as it is in the Cleveland Clinic learner pathway. I keep saying learner because it was a traditionally learner pathway, and then they introduced us PACE program students into it. there were a lot of other things that basically just stood out to me with the Cleveland Clinic program, but those were really the main ones for me.
That's great. Thank you so much. I want to ask Henry and Dennis and Dom. I'll start with you, Henry. Can you talk about why you chose the traditional core and kind of how your experience was training at multiple different hospitals?
Yeah, absolutely. So I wanted to see how multiple systems worked. And kind of for one of the reasons that Sophia decided not to do the traditional track is one of the reasons that I wanted to, is to see multiple different EMRs, how they function. I mean, yeah, that first week sucks when you're dealing with the CPRS, which is this super outdated EMR that's a pain in the butt to work with. But I thought it was a useful experience because I'm not really sure where I want to do residency and where I want to train. And I figured having a couple different EMRs under my belt would help. So I wanted that. And then I really do think that you see how each hospital operates differently. And I think that helps you kind of figure out where you want to practice in the long run. I mean, obviously residency will help you hone that in, but I thought for me personally, I wanted to figure that out a little bit earlier and see, how does an academic center like UH run versus the VA, which has a completely different system versus more of a community-based system like Metro. So that was really important for me. And I think one of the things that a friend told me when I was trying to figure it out was you'll spend a lot of time, kind of debating which one you want to do. And then you get down to it and you realize that you get a great education regardless. So going back to kind of an early thing we talked about is how many spots does the CCF track have? I think maybe 1 or 2 students don't get it every year. It just kind of depends on how many people apply, but everything works out, and both tracks, including Metro as well, are fantastic.
Thanks so much, Henry. I know there were like 56, it might have been up to 70 students. And I know they've had a lottery the past like 1 or 2 years where there were a small handful, might have been 2, might have been 3 students that weren't selected. It's a random lottery. So you generally can train where you like. I know there were years where they haven't had a lottery either, to my understanding. So there, I guess you generally can train where you like. There are a few exceptions, but it is pretty flexible. Dom, go ahead. I'm curious about your experience kind of doing multiple hospitals and kind of how that has worked out and what that experience has been like for you.
Oh, I actually did the longitudinal track at CCF.
Oh, you did your lunch. Oh, I'm so sorry. Go ahead. Sorry about that.
No, it's okay. But I think like my experience is very similar to Sophia's because I want to do cardiac surgery. So I thought for me, like going to CCF and getting exposure early on to the cardiac and the vascular surgeons was a little bit of a leg up. You could totally do that in the traditional pathway though. You have elective rotation. So it's not like you just totally miss out on the experience at the clinic. It's just like for me, I thought like one hospital system, one EMR, it's easy. I know where to park. I can just pull up. I know where everything is. And then I get to know the attendings a lot better. So I think that was the only advantage for me.
Dom, have you done so when you're doing all your rotation, are you on Cleveland Clinic Main the entire duration of your 3rd year? Are you doing some of the satellite campuses at Cleveland Clinic throughout the region, or is it kind of a mix of both?
It's a mix of both, but it's asymmetric. So I would say it's probably 80% of your time is spent at main campus.
Wow.
And
Okay.
then when you do like maybe OB or they have an outpatient longitudinal track, in which case some days, like on Tuesdays, I would go all the way to Brunswick. And then for OB, I was at satellite campus in Fairview. So.
Excellent. Thank you so much.
Mhm.
And Dennis, I just want to ask you as well, kind of similar to Henry, being able to kind of just think about multiple hospitals and how that experience has been for you.
Yeah, I think my answer is going to be kind of similar to Henry's. I was also partially motivated by the fact that I spent a bit of time as a nursing assistant at the Cleveland Clinic before starting at Case. So I felt kind of a little bit like I had my feet in the door there, or at least like seeing kind of what day in the life on the wards was like there. So kind of similar to Henry, I wanted to see kind of what like a safety net community hospital like Metro would be like, and kind of see UH academic kind of being kind of toe to toe with where like the old med school was. So you can kind of bounce back and forth there. And then even the VA, I think, has been kind of, was it like a useful opportunity to see what kind of a federally run kind of healthcare system could look like. So yeah, I think kind of having that variety of experiences and seeing what draws people to those different institutions was very useful. But then kind of still planning for AIs and kind of thinking about that too, to how to round off kind of getting the experiences that you want. And I do think the EMR and kind of adjusting from system to system is maybe a con, but it's not something that kind of can't be overcome by asking around and kind of trying to figure out how. But I will say the VA is probably the worst about kind of EMR adjusting. Is just it's really locked down in terms of a system. So making sure you're getting all your paperwork in ahead of time is kind of important there.
Good advice and insight. Thank you for that. I saw Beck had a question about doing some research. If you're training at this hospital, mainly like you do one of the longitudinal programs, can you do research with a mentor at another hospital? And thanks for taking that, Henry. Yes. Is that the case with Dom or Sophia? Did you all do your research mostly like through your research mentor worked at Cleveland Clinic? I just was curious if one of you wants to comment on that.
So I think there's a couple of like tips and tricks. Like if you want
Okay.
parking by the HEC very early on, I think get onboarded at CCF and do some research. That's nice little insider information. If you do the longitudinal track, like there's a bunch of like little perks too. Like you get remote access, so you can do research without having to go into the hospital, which is pretty hype. And to more directly answer your question, like I did research at CCF from year one, and then just kind of continue that. But then I also have like a couple of offshoot projects with UH mentors and Metro mentors. That was pretty easy too. Like it's totally separate. It doesn't impact the third year at all.
Thanks for that, Dom.
Yeah, I didn't want to. Okay, good. Yeah, no, just like Dom. Can you still hear me?
Loud and
Okay, good.
clear.
Awesome. Just like Dom, very similarly, I started research my first year. I started with a PI that I really liked through my pathway. I'm also in the World Medicine pathway here at Case. So because I already had that relationship with her, we were able to get me started pretty early and at UH. So I did research throughout my first 3, even to this point, in UH. However, I was also onboarded my second year to CCF, and just like Dom said, that's really, really nice to have if you're doing the learner pathway, because you can do a lot of virtual research without having to be on campus.
Excellent. Joseph, I saw you had your hand up. If you want to ask a question, go for it.
Yeah, thank you for that. And thank you all for being here. Also, Dom, I haven't seen you on DeSanto Field for a little while in our little pickup group. Congrats on your match. That's wonderful. I'm really happy for you. I wanted to ask a quick question about how the rotations are ordered. Is that something you choose, whether you start out in OB or you start out in primary care, you start out in surgery? How are your core rotations ordered, and how much choice do you have in that?
I can take that one for traditional. I don't know if it varies for CCF. It might just be the same, but you get randomly assigned. And then from there, you can work with other students to switch schedules if you'd like. Like I know if people are kind of hesitant on surgery, whether or not they want to do it, they try to do that in the first half. So if they get a schedule where it's in the second half, then they'll try to switch with another student. But yeah, it's not like you can really submit preferences, unfortunately. But you know, again, you'll spend a lot of time stressing about it and worrying. And then once you actually do it, you realize part of it doesn't matter. You're getting the same rotations at each place. So it all works out in the end.
Yeah,
when
and
you-
then
oh, go ahead,
sorry.
Dom. Sorry.
Sorry, Tom. I was just going to say, like, I think one of the advantages that we haven't talked about the traditional pathway, and Harry and Dennis can Denny can kind of like add to this, is that you can kind of pick the rotations that are like lighter, if you catch my drift, in terms of the traditional pathway. So like you kind of locked in on the CCF pathway in terms of like, if you're going to do peds, it's a set schedule. They have the institutions already planned out. And like on the traditional pathway, you can pick UH for peds, you can pick Metro for peds, and that experience might be very different. And you can like kind of talk to your classmates about that experience is like.
Thanks, Dom.
Yeah, that's a great point. The variation in kind of how you're going to experience the rotation depends a lot on the institution itself. Like UH Peds is fantastic, right? It's Rainbow. It's a huge, huge center. Metro Peds is still great, and you see a lot of the kind of day-to-day things, which it's kind of cool as a person who's not interested in peds. I did at Metro because I wanted that experience in case a friend calls and is like, hey, my kid's, not feeling well. What do I do? I think that experience was very helpful. It also was a lot lighter than the UH track because the Rainbow just deals with a lot more complex problems, and it's fascinating if that's what you're into. It's not what I'm into, so it was cool to be able to not game the system, but preferentially select where I wanted to do rotations.
Yeah, and I guess building off of that point, you can kind of take that example and apply it to kind of all the core rotations. So just thinking about kind of how you want to practice or things you're interested in, and you can kind of shape, okay, would I want to see this in a more community setting? Especially like for the surgery one, do you want to kind of see it more in academic, or do you want to see, especially since emergencies lumped with, so I know a lot of people that kind of preference Metro to get that kind of emergent and trauma experience. And so, yeah, you can kind of think about that. Okay, with internal medicine, do I want to see that in academic? Do I want to see that in community? And I mean, not that Metro is not an academic kind of because it's teaching kind of through CASE, and there's a lot of people there that do research at CASE. But you can kind of think about that for each, of your core rotations. It does offer that flexibility. And that is also kind of a thing where, like the ordering of the schedule, you kind of preference and you get assigned. And if it's not the one that you picked, you do have the ability to kind of switch with someone who has their core lined up as the same as you. But I think I've gotten most of the ones that I've preferenced.
Thank you so much. I want to ask, there's a good question in the chat I kind of want to get to. I know Yiming asked, like kind of the research, mentorship, specialty guidance and connections, like to help you prepare for residency. Like, so I guess to kind of, I'll expand upon that too. When you're in your third year, are you thinking about a specialty yet? Like that you're dead set on? Do you have to have an idea of what you're going to be doing? How does like that kind of guidance happen when you're kind of in training in terms of identifying your specialty and getting ready to apply to residency? Like, sure, it happens over the course of the entire third year, but could anybody speak to that a little bit as well?
I can take that because I feel like I have a lot of experience with that myself. I essentially would highly recommend like locking in sometime before the end of the half of the year, basically. So just because I really didn't decide on anything until I would say maybe 2 months before ERAS was due, and I felt like I needed a little bit more time even then. So I do think going into it with a very open mind is very, very important. You will learn and see a lot of things that will change your mind as you are on the wards. And you might even find that what you thought you really, really loved is not exactly what you want to do. But I do think that as time progresses, there's so many people surrounding you who are happy to speak with you with regards to what would be a good course of action to take. I do think that the curriculum has been changed a little bit since my third year to give you a little more time to do AIs. And I feel like those are very, very nice to help you also hone in on what you want to do specifically. But yeah, I think that as the year progresses, you will know what you don't want to do. And I think that is a very good indicator towards what you should be doing.
Yeah, I feel like I'm sure there's a bunch of other meetings and about this today, but like at CASE, there's a bunch of interest groups that often allow you to be plugged in with mentorship or research opportunities very early on. I think the conventional wisdom that I've heard is like whatever you're interested in that's the most competitive, try to go for research for that, and that's pretty easy to get set up at CASE. I think like picking a specialty of choice, I agree with Sophia, you kind of have to know by the first half of third year so you can start planning for letters and things like that. But I think CASE really allows you to shadow very early on, like in the first year of medical school, so that in 4 different institutions, so you can kind of get exposure to a field, but also see what it's like academic community practice, what have you.
So like, I guess I was curious, when if you don't know what specialty you're looking to do when you start your third year, is that okay? Would you say that you're still is it, yeah. So like sometime during your third year, you've had a lot of time to explore your first 2 years, special interest groups and things like that. But would you say like most students are starting their third year and they're still not dead set on a specialty? Would you say that's more common or the latter?
Absolutely. I would say that's more common actually. And I
Okay.
think a lot of my classmates changed their minds about whatever it is that they wanted to do. I would say a good, at least half of our classmates that are not going into what they thought they would be going into.
Okay.
I think going in with a very open mind is the best way to do it.
Excellent. Thank you for that. Could we talk, I know Joseph had a question about the acting internships. And I guess those are in your third or fourth year, maybe clarify that, and then, or it's fourth year. Thank you, Henry. And I guess, and I don't know if everyone's done those. I know, Dom, you were fourth year. So if you could maybe speak on what that experience was like, and if others can as well. Just, I know you're in a little bit more of a leadership role, and you've had some, the hospital work and experience, clinical experience under your belt as a medical student. Could you just kind of share what that experience is like, and how it is maybe a little bit different than when you're starting out in your third year?
Yeah, the sub-I AI, same thing, acting internship, sub-internship. And I think at Case, when I was a third year, it's probably changed, but you could do a sub-I or an acting internship if you hadn't met the prerequisites. So like if you want to do a surgery AI, you have to do the surgery clerkship unless you have an exception. And then in the fourth year, basically the difference between a sub-I and a normal clerkship is that the responsibility is a little bit more elevated in the sub-I. So you're supposed to be functioning like an intern. And I think you're supposed to kind of see it as like a job opportunity, like you're, whether it's at your home institution or an away institution, you're kind of sort of trying to put your best foot forward to show that you can be an intern next year. What that means is carrying multiple patients, being responsible for them, writing notes on them. And it kind of looks the exact same as a third year student, but the team just kind of trusts you a little bit more. So I think that's kind of it. I think in terms of like feedback, evaluation, that kind of stuff, it's the exact same. Oftentimes, like you'll notice that being a third year is not that different than being a fourth year. You're just expected to be a little bit more sharpened. And usually people do it in a specialty that they're interested in. So you tend to be able to show yourself, you tend to be able to show your skills a little bit better than if like I, as a general surgeon on my neurology clerkship, maybe I'm not so good,
Excellent.
I do want to add a little bit to that. Sorry about that.
Please.
I would disagree slightly with Dom in terms of like your workload from third to fourth year, only in the case where whatever it is that you were interested in happened at the beginning of your clerkship. So say, for example, your first clerkship was a PEDS clerkship, and you decided that you wanted to do PEDS AI at the beginning of your fourth year. So essentially an entire year has passed since then. You'll have a lot more experience, and the way you will be approaching your sub-I will be very different, simply because when on your first clerkship, most institutions will be a lot more understanding. So my experience is that when I started on my PEDS rotation, I was not expected to carry more than 2 patients because it was my very first clerkship. But as a sub-I, you will want to carry a lot more than 2 patients. I would think of a sub-I as essentially being an intern, and the only thing that you're not doing is signing orders. So you're actually acting as an intern.
Excellent. I know, thank you for answering one of the questions in the chat there, Henry from Beck. I guess talking about shelf exams, when do shelf exams occur at the end of each specialty? And in terms of preparing for that, is there any kind of like week before that you get like off to prepare for that at all, or no? And I guess how does that whole thing work?
As a person taking shelves in 2 weeks, I can start.
Yes.
So you take shelves, yeah, it's a lot of fun. You take shelves at the end of each rotation. So depending on the track that you're in, you'll take different shelves at different times. So the traditional pairs, psych and neuro together, internal medicine and family medicine, OB-GYN and peds, and then you take surgery alone. I know that's different from the CCF track. You don't really get any extra time scheduled like from Case. You do in certain rotations get specific like study days and whatnot, which is great. Like internal medicine gives you some half days. OB-GYN gave me some half days. So, some rotations are more lenient than others there. You just kind of figure out how to make it work. Your first 2 years, you figure out what works best for you in terms of studying, whether that's, certain resources, certain strategies, and then you figure out how to master that for third year and just apply it and you go. There's specific like question banks that everybody uses, common resources. So you figure it out, and the first rotation is definitely difficult because you're just figuring out how to be a student in the hospital as well. But yeah, I think you'll surprise yourself that you kind of just keep going and you will figure it out. It's daunting from the outside looking in, but looking back, you just make it work.
Yeah, I think there's a lot of I don't know what everyone did, but there's a lot of, some people think that you can study while you're in the clerkship, like while you're supposed to be like rounding and seeing patients. You'll find during the day you have downtime and you can maybe do a couple of UWorld questions or Anki or whatever. And some people totally think that you should just wait until after your clerkship is done when you're at home. It's whatever kind of like, you'll kind of suss out your team and like do what kind of fits your own opportunities. I think I would use a lot of time on the weekends to really hammer in some Anki decks. That was really important for me. And then I would just do like UWorld the week before the test. I just have a question for Denny and Henry. Like, sorry, Tom, I know this is your thing, but we in the CCF pathway take like the grouped shelf exams at the very end of the like 3-month like rotation. Do you guys take it at the end of your 3 months or at the end of the clerkship? Does that make sense? Like after you do 4 weeks of neuro, do you take the neuro shelf or do you wait?
No,
until
we take them paired like
I
you
see.
do. I think the difference is your surgery and IM is together and then your FM is separate, if I remember correctly. Which I think was nice for traditional because it's tough to study on surgery. I think that one's just the most demanding in terms of time. But no, we take them at the end like you do as well.
Yeah, so that's nice because you get this 2 months, or for us it was 3 months to study for these 2 shelves. And that way you had a lot of time to kind of prepare for it.
So there is a slight difference then. If you're in the launch, okay, wow, interesting. Small, yeah. Yeah, Dennis, go ahead. If you want to add anything.
Yeah, and I guess one difference, like kind of Dom was mentioning, like if it's at the end of the clerkship or at the end of the block, because I know some other schools like after. I think one thing that it's important to keep in mind, the pro is that you have 2 months to study for neuro and psych. The con is if you do neuro first and then you do psych, you kind of have to keep the neuro fresh.
Yeah.
So that's just one thing to think about. But the pro is now you have kind of double the amount of time. And then I guess jumping back to like going into third year open-minded, I think this kind of also links with shelf exams is like, if you approach kind of each rotation with that open mind and with the like, okay, now I'm going into pediatrics and I'm going to like approach each day like I want to be a pediatrician and like try to get the most out of your team. Like I think that helps with the shelf performance as well. Because then you're kind of like trying to soak up every little bit of information you can. You're asking questions, like that'll reflect well in your clinical performance, but then it also kind of translates to your shelf performance. And you really get to kind of see, okay, when I was like a pretend pediatrician for a month, did I like that life? Or when I was a pretend psychiatrist for a month, did I like that life? And you can kind of sort of, it helps you with that decision, but it's also helps your performance, I think, clinically and on the tests as well.
Excellent. When I was curious, more for Dennis and Henry, when you're in the traditional core, and I know we kind of talked about this a little bit, but when you have like your 3 different, you have the VA, UH, Metro, do you submit like preferences like, oh, I'll take psychiatry at the VA and I'll take emergency medicine and OB/GYN and peds at UH? Is that typically like, how would you just list like, here's my top choice hospital for this specialty, and then if you don't get it, you can maybe switch with somebody generally, if like there's always probably multiple people or hopefully that just don't have a preference where they do a particular rotation. Is that typically the case, or just, I guess it just depends?
Yeah, you submit. So you start by submitting your preferences for each one, but you can change that throughout.
Okay.
And like Denny mentioned earlier, if you get placed at Metro for rotation, but you really want to be at UH, it's pretty easy to switch with somebody. The class group meets are, you just throw it in there and then somebody typically doesn't really care and is willing to switch. So there's only been a handful of instances, I think, when people haven't been able to change, but they've made it work.
Excellent.
And I guess one other thing to add is there's like preferences within preferences. So once you're like, okay, I'm UH for IM, you can like choose, okay, I want to be on like this specific team. like in like a couple weeks before the clerkship coordinator will reach out to you. So you can get kind of fine tuned with like what you want to see and who you want to work with. And you don't always get what you want, but there's like kind of some elective choice even within the full like kind of core clerkship. So
Yeah.
customizable.
I want to jump over to Dom because I know congratulations again on the match. And I guess I want to ask, tell me where you matched. Tell us where you matched and how long your residency is going to be, and just talk about the overall process. I'm sure there's some relief that it's over now. But yeah, just curious to hear about your experience and all of that. And if you were, gosh, this is what I expected. This was a little harder than I expected, or kind of things like that as you went through the process.
Yeah, I'm going to the University of California, San Francisco,
Okay.
doing general surgery. I'm interested in cardiac surgery. So they have like 3 different major paradigms to get there. There's the integrated thoracic surgery track, there's a 4+3, and then there's 5+2. In the 2 latter ones, you do general surgery first. UCSF has a 4+3 pathway, which I thought was like the best thing ever while I was going through the like deciding between 4+3s and I6s. As far as, sorry, I'm winded. As far as the opportunity to apply residency goes, like I think you did 3rd year, you go through every rotation. Like you want, like Denny said, you just want to be singularly focused on whatever that is so you can honor the rotation. You do that, you get research mentors lined up, you get people who can advocate for you in the field, like everyone says, and then just kind of make a portfolio for ERAS. It's very expensive. Like I had to apply to away rotations, and then I went to 3 away rotations at UPenn, Columbia, and Cedars-Sinai, and each one was like $2,000 for that whole month, and like going there and being there. So that was expensive. And then like the application for ERAS was like $1,500 to apply for residency for 2 different tracks. I applied like 70 programs. And then as far as like interviews go, like in 4th year, you can kind of like carve out time just to do interviews. So in November, December, I was doing research, which is great. And I just, every day I had like an interview lined up. Some days I had 2 interviews, and then I just went to all these interviews, and then it was kind of just chilling until January when I did another away rotation, more interviews. That was kind of a whole thing. And then you kind of in February just take time I did like a surgery boot camp, which is really a great opportunity to just kind of like know how to put in A-lines, central lines. And then during that, I was also like talking to residents, talking to attendings about like their experiences, like where should I put I6 programs, where should I put 4+3 programs, which one was the best for me. And then I kind of made a rank list, and then, the rest is history.
Matched.
I think as far as like this medical school, I honestly think this is like the best med school in the country, like as far as like being able to see opportunities, be able to like get any kind of exposure to any field of medicine that you want. I think you can go anywhere that you want in terms of like location, in terms of specialty. Like literally we matched 13 orthopedic surgeons this year, which is absurd. So yeah, I think CASE is great. And I think as far as like facilitating the match process, there's like 4 different institutions you could sort of rotate at, get research mentors from, and then just there's 4 opportunities here in Cleveland to match, which is also a great thing. So I think it's the best medical one.
Excellent. Thank you. Thank you. Well, congrats again. Exciting times lie ahead. How long will your general surgery residency be?
Oh yes, sorry, I never answered that. So
Oh, you're fine. No, you're good.
UCSF has 5 years of general surgery training clinically, and then 2 years for research. And then because I'm doing the 4+3, it's basically 4 years of general surgery, 3 years of cardiac surgery training, and then 2 years of research. So for a total of 9 years. So I'll be in the Bay Area for a very long time.
Bay Area will be your home for all your training. Wow, good for you, Tom. Best wishes, good luck, and wow, keep doing great things. Thanks for sharing. I have a couple. I saw someone Joyce dropped a question in the chat, kind of like just about improving as you go along in your 3rd year. So you've had your first 2 years of med school, you get into your 3rd year, and obviously you're going to learn things more as you are interacting with more patients, as you're kind of maybe presenting patients, for real, as well, and you're kind of doing the thing. Like, would you say, like, maybe speak a little bit about how like you've improved over the course of your time, like, exams and, you had all these things you were preparing for in the basic sciences and the classroom, part of your med school experience. Just talk about like how you like improved over the course of years 3 and 4. I don't know if anyone wants to kind of speak on behalf of that a little bit. Or maybe some things you learned along the way. Go ahead, Sophie.
Yeah.
That's okay.
For sure. You will find third year to be the most transformative time of your career in like medical school. Just because you will see how much improvement there will be between the first day and the last day. You will have a lot more confidence and you would have done a lot more during that time. For sure, I can distinctly see my first day of third year and know that I was absolutely not good at a lot of things, but I do feel a lot more confident now with a lot of different procedures as well as my medical knowledge. As far as improving your medical skills as you progress through your clerkships, that I would highly advise to be very, very engaged. Everyone on the panel has already said this, but the more engaged you are in your team, the better you will learn, the more information you'll gain for yourselves. And on some real stuff, you will get a better evaluation at the end of the day because they will know that you were very, very curious and involved with the care. Now, I would highly recommend asking to do anything that is like on the table. So if your intern is doing a central line, sometimes they won't let you do that, but at the very least, you should essentially say, hey, I'm really interested in learning how to do this. IVs, when you are in surgery, they do so many of those. Anesthesia is right there. You could always say, hey, can I practice doing IV lines here? And you can do that for pretty much every surgery. So there are sometimes they're going to say no because it's complicated. They have complex patients, but they're usually very happy to teach you. And the more you practice, the better you're going to get at it. First and second year, you will have some workshops that they have in order to teach you how to, at least the basics. And as you're progressing through third year, at least at the CCF pathway, before each 3 block, we usually had a workshop that would teach us some things that we could actually do on the wards as well.
Excellent. Very insightful. Thank you, Sophia. Anyone else want to speak on their personal experience with that?
Yeah, just to echo that. I mean, I think for procedures specifically, just being a go-getter and kind of getting after it and taking control of your own learning is very important during third year. And being engaged, right? Studying hard, getting those pimping questions right, like those help show people that you are interested and you're serious about this, and they're more willing to let you do things to get you more involved. So studying hard and getting the things done that you need to pays off not only with yourself, but then impresses your team and then can help you get access to more procedures and whatnot.
Yeah, I would say like you kind of learn by osmosis in third year, but it's facilitated if you are really engaged, like everyone said. So like, for instance, like I think the hardest part about going from preclinical student to a clinical student is like you're not really calibrated to when to anticipate that a patient might deteriorate, or like you haven't done like an abdominal exam on a patient with an actual pathology, just been doing standardized patients to that point. So like just being in the hospital and seeing things, you kind of get calibrated to like, okay, this is abnormal, this is normal. So I think that helps. Once you're engaged, I think some of the advice that someone gave me was like, don't be afraid to literally ask your resident, oh, well, when I saw this patient at 3 rounds, I thought that, this epigastric pain that they had was just normal. What do you think about that? And then they literally can then say, well, no, he's been like this for a week, or no, this is normal because of blah, 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 blah. And then you learn more, right? Like if you see a drain putting out like a weird color that you've never seen, take a photo of it and then ask your, resident, like, oh, like, what is this? And round, like, what do you think this is? I think that way you can kind of like get actual feedback real time about your clinical evaluation of a patient.
Excellent.
Yeah, and I kind of think you like we've talked about, you get out what you put in. So you can easily kind of get by, but then you aren't learning. And so like putting yourself kind of out on the line, like Dom saying, like, okay, this is what my thinking was. Like, it gives them the opportunity to correct your thinking. And I like talking about my own progression. I just know, like, very early on, I did like neuro and psych were my first two, and like one of my first like presentation was neurocritical care, and like I'd never really like officially given like presentations before, and it was like systems based, and they kind of wanted everything a certain way. And I just remember like a couple more, like 2 mornings in a row, just like fumbling through that, and you just like are kind of really thinking and worrying about like, okay, this is how like they want it. But the thing is, like, things go well when the whole team succeeds. So like everyone wants you to do well. It's not like people are like, oh, that's the med student, we want to see the med student like do bad, because then it like the resident's looking, like the attending's looking at the resident who's looking at you, everyone's standing and watching you, like everyone's happy when things are going well and smooth and patients are getting good care. So look to your residents for advice. Like then, you know, they saw me struggling kind of that first day. I was asking them, okay, like how does this attend? And even it'll vary attending to attending. So as soon as I got it down for one attending, when we switched, it's like that's a whole learning process too sometimes. So I think like looking to the people around you to help with that growth process over the years is really key, because you know they know more than you. They've kind of been through all these experiences, and kind of guide your thinking and kind of help you through that process, so you don't stumble as much as you did at the beginning, and trying to stumble less and less and less over the course of the year.
Excellent. I want to ask one more question. I get we get some questions here in admissions about the grading scale, your third and fourth year. I know it's complete pass fail your first 2 years, but if someone, I know we have a minute left, so we're going to talk real fast. But if someone just wants to comment real quick on is that something that a lot of people are eyeing closely, the grading scale at all your third and fourth year, or no? Someone just take it.
Yes. You are eyeing it very closely. You do want to, most people want to honor as much as they can. And lastly, I would just recommend remembering that there's a third year and there's a fourth year, and you still have the chance to do a lot of clinicals in fourth year. So I would remember that third year is essentially like an evaluation, versus fourth year is like really to get to enjoy things that you really enjoy.
Thank you so much. I want to thank all our panelists. Sophia, thanks for that quick rapid fire response too. Dom, Henry, Dennis, you were great. We really appreciate you coming to the panel today, and thank you. Hope this was informative. And the next round of panels are coming up here. We have a 5-minute break before our next set. So everybody, thank you. Denny, Henry, Dom, Sophia.
Whoever had the question about parking, feel free to reach out to me, and I'm more than
Go ahead and get started here. So this is the part 2 of your of the revisit day for our student panels. We have 4 fantastic M3 and M4 students that are with us, that are going to be on our panel here. We have if you just want to like wave or say hello, we have Teresa. Hello, Teresa. Nice to see you. And we have Rebecca Russell. Rebecca, nice to see you as well. We have Jared Anko. Hello, Jared. And we also have Ashley. So thank you all so much for being here. I'm just going to start and have maybe each of you just introduce yourself and just tell us your name, your hometown, how you structured your training. So if you did the traditional core, the Cleveland Clinic clerkship, or the Metro clerkship, and what is your specialty interest? I think I have all third years on the panel here right now. So no one has applied to residency, I guess, formally yet. So hometown, the rotation that you chose, and what is your specialty interest? Teresa, I'll start with you.
Sure. So hi, I'm Teresa, M3. I'm from Denver originally. And I went to Colorado State University, and I chose the Cleveland Clinic track for my third year. So I'm kind of wrapping that up now, and I'm planning to apply into internal medicine.
All right. And Jared, you can go next.
Hello, I'm Jared, also an M3. From Oklahoma City, went to school at Northeastern University in Boston. I'm doing the traditional path, and I'm doing psychiatry.
Excellent. Thank you. And Ashley, go ahead.
Hello, I'm Ashley, third year medical student. Originally from Austin, Texas, went to school at University of North Carolina, Chapel Hill. I am doing the Metro longitudinal tract, and I'm also applying to psychiatry.
Right, cool. And is Rebecca here? No, I don't see Rebecca. Oh, looks like she just popped in to the waiting room now. So she should be here momentarily. So we are also going to be joined by Rebecca Russell as well. Okay. So I'm gonna I guess I'm gonna start with you, Ashley. I know the Metro clerkship is a very small clerkship. Can you talk a little bit about why you chose the Metro clerkship and what it's been like doing all your training at one hospital and a public safety hospital in Metro? Probably see a diverse patient population. Just curious to hear about your experience, why you chose that way to structure your training, and how it's going and how it went, so to speak.
Yeah, it's insane. It's almost coming to an end. Metro longitudinal program. I chose it because of the longitudinal relationships that you get to develop with your assigned preceptors. Usually there are only 3 to 4 spots per year. Dr. Raddick, the program director, is trying to increase the availability of that. It is all dependent on having, preceptors who are willing to work with medical students for an entire year. So that's a pretty big commitment for them, but it's really, really valuable being able to work with the same. I think there's 4 preceptors that I have. They really get to know you. I am working closely with a lot of them. It's like they're my friends. The letters of recommendation are going to be really in depth because they know me so well. So that's really why I chose it. But it's really focused on primary care and outpatient medicine. So if you're interested in going to internal med, family med, even something OBGYN, for me, psychiatry, I think it's a really great option. And I really, really enjoy doing all of it at Metro. Like Tom said, it is a safety net hospital. It's very diverse. You see a lot of very sick patients. You see a lot, and it's sad. It is really, it's sometimes really hard, but it's also very rewarding to participate in these patients' care and to, know that you're making an impact on their lives. I get to also, in some instances, see patients longitudinally. I've seen them in different settings too. Sometimes I see them in the hospital and then I'll see them outpatient. So I feel like I have a good sense of some of the patient populations and the providers. So that's a big benefit to working at the same hospital for all of your rotations.
Excellent. I know there's also a Pride clinic, and there's also a Spanish speaking clinic as well. And not just even if Jared, I know you did the traditional core, and Rebecca, as well. If when you're training at Metro, do you have opportunities like, if you have some fluency in Spanish, you're able to work in the Spanish speaking clinic or vice or something along those lines? Is that something you have the opportunity to do at Metro as well?
Yeah, I can address that really quick. Absolutely. There is in Ohio City a very predominant Puerto Rican population. And the Ohio City clinic for Metro has a lot of Spanish speaking providers, and they have a Spanish clinic. So one of our LIC students is working there. She gets to speak Spanish with the patients once a week. And then, I've actually been able to participate in the Pride Clinic at Metro. It is so awesome. They have a multidisciplinary service. I was able to go through my internal med preceptor. I'm with him normally in just his general clinic, but he also services the Pride Clinic. So I, kind of did an extra thing and asked if I could go see the Pride Clinic, and it was really awesome. And there are also some other things at Metro, other opportunities, unique clinics. There's a sexual health clinic that my OBGYN preceptor is the medical director of. So very unique, very interesting, very diverse. There are lots of opportunities.
Excellent. Thank you. I want to let Rebecca introduce herself as well. Rebecca is our 4th panelist here. Rebecca, we're just introducing ourselves, how the panelists, name, hometown, what specialty, how you structured your training. So traditional core Metro Health clerkship or Cleveland Clinic clerkship, and your specialty of interest.
Hello, everyone. I apologize. I was having technical difficulties, and then I sat in the main room. So
you're good.
But I'm from Cleveland. I did the traditional pathway for my rotations, and I am applying to OB-GYN.
Thank you. All right. So I know, and Rebecca, and I want to ask Rebecca and Jared kind of this next question, and asking about, like, you all chose both chose the traditional core, so you had the opportunity to train at multiple hospitals. Could both of you just share what that experience has been like? learning, different structures of different hospital systems and how the culture, atmosphere, patient population, so many different things come into that. Just curious on what your thoughts were and why you also chose the traditional core as well to just how to structure your training.
I can go. So I decided to do the traditional core because I knew that during fourth year you have the opportunity to do electives and like some internships. So I knew that if I did not, choose the like Cleveland Clinic pathway, for instance, I could, experience Cleveland Clinic in a different format. And then I thought in terms of like doing the long-term Metro Health opportunity, I was like, well, if I do the traditional, then I automatically get Metro and then I get opportunity other ones. So I just did it in mind that I wanted diversity, and I knew that doing the traditional didn't necessarily limit me during my third year. So the differences between the systems, I think that, well, one big thing is like the electronic medical record is different between both hospitals. So there's one barrier to going into third years. You don't really have much experience with the EMR from a clinical standpoint. So just learning the EMR in the first place is a barrier. And then maybe like bouncing back and forth may also be one. So like I did Metro at the beginning of my third year, and I'm at Metro at the end, but in the middle was like university hospitals. So when I came back at the end of the year, I'm like, I do know how to use Epic, but I need to remind myself. So that's one thing that's different. But university hospitals is going to transfer to Epic, so that may not be an issue in the future. Another thing is, again, let's talk about like patient populations. Cleveland overall has a very sick population for the most part. You have a lot of medically underserved individuals. So across most of the hospitals, you will get experience learning how to take care of people with very complicated medical backgrounds. But I think that the way that things are handled in terms of like insurance or programs that patients can participate in is different across the hospital. And there's like a lot more support with Metro for things like that. And then it's also like what Ashley was talking to, like I was at the Ohio City for family medicine. And again, I had those opportunities to work with Spanish speaking populations, which wasn't necessarily always there at university hospitals.
Thank you.
Yeah, I think I chose a traditional pathway because it does have opportunities to work at different hospitals and different settings. I think since each rotation is really a couple weeks, couple months, which is not enough time to like really get a feel for the entirety of the field. And I think going to different hospitals, different systems kind of highlights differences and like forces you to look at things a little bit more critically and kind of examine your experience more. So I think that was really helpful in kind of getting the most out of those different experiences. This wasn't my intention going into it, but I did my internal medicine rotation at the VA here in Cleveland. I really loved it. It was rewarding working with the veteran population, and to be able to give back to them to some degree and learn just like what the VA health system is like. I really had very little idea and got a sense for like just the whole VA system and was really impressed by it. Yeah, I think just getting to see different places has been really valuable.
Thank you for that. All right. So I want to ask now, Teresa, I know you're the only one on the panel that's done the Cleveland Clinic longitudinal clerkship. Could you just share a little bit about your experience, why you chose to do your training at Cleveland Clinic and how that experience has been as well? You're good.
Okay, sorry, I've been having some mute button issues. Yeah, so I was hoping to do the Cleveland Clinic track and was able to get that. And I was excited about it because, I mean, definitely a piece of it was that, Cleveland Clinic has this amazing reputation, which all of our hospital systems are great, but I was excited because I'm in Cleveland, to see, what the Cleveland Clinic is all about. And I also expected that it'd be nice, you're just onboarded to one hospital system, and then even if you're going to different locations around Cleveland, that it's all part of the same system, so you don't have to worry about some of those extra kind of logistical steps. And yeah, so those were some, and another reason I chose it was because you have this in some ways similar to what Ashley was describing. You get kind of this longitudinal experience over 3 months of doing, where it's like all outpatient rotations. So you'll see, like, I saw the same family medicine preceptor once a week for like 8 weeks or so, and like spent a whole day with her. So you do get to build a little bit of that more kind of longitudinal relationship with some of those preceptors. And also I thought it seemed like you got maybe more outpatient time, and I foresaw that I might be interested in like family medicine or something. But yeah, and so I have really enjoyed it. I feel like even in ways that I didn't expect. Like, I think Cleveland Clinic has ended up being like very welcoming to medical students and very teaching focused. And I feel like maybe I heard rumors kind of saying the opposite in some ways, but like I've had such an excellent experience, like very hands-on. I think any rotation anywhere, like you get to be as involved as you want to be, basically. So everyone's been so welcoming. I've learned so much, and you still do get to see how different teams and locations do things a little differently. And then I think my 4th year, you get to still do like additional like electives and other types of rotations at those other hospitals. So I am really looking forward to seeing how university hospitals and Metro and possibly the VA, do things. And I think like I'm a little nervous to adjust to those new places since I haven't had to do that yet, but I will still get that exposure. And then I think that will prepare me well for adjusting to wherever I do residency as well.
Excellent. I want to thank you. Thanks, Teresa. No, that was great. I and thank you all too. I know you've heard from all our panelists now. I want to invite anyone that is interested to just drop any questions in the chat, or if anyone just wants to like unmute their mic or maybe use that raise hand feature on Zoom and just wants to ask any questions to our panelists. I also have some questions I can continue to ask, but I definitely want to open it up for questions just to kind of make this worth. And I see we have our first one. Go ahead, as Juma, excuse me if I mispronounce your name. Go ahead, if you want to ask, go for it.
When you guys started at Case, like, did you have a certain rotation, like a pathway in mind that you wanted to do, and then ended up changing your mind when it came time to pick? And if so, like, why did you change your mind?
Good question.
I can start. Oh, Teresa, did you want to go? Okay, I'll just quickly say I had no idea. I do actually remember in my interview day somebody mentioning Metro Health. I think, everyone knows of Cleveland Clinic. Most people know of university hospitals, but I remember somebody saying Metro Health really is a great place to get really good medical exposure. And that kind of stuck with me. And then I talked to the program director about the program and figured out it would be a good fit for me. So I really decided whenever the whole application was due and they were kind of reminding us of it. So I think that's generally the case for most students.
Yeah, and just to add on slightly, I feel like when I'm coming into medical school, like 3rd and 4th year seemed so far away. And so like, I was like, I guess I'm doing something clinical at some point. Like, I don't even, it's hard to be that far ahead, but I do think something that Case really offers, no matter what track you choose, is that there are like so many hospital systems right here in Cleveland. So like friends at other medical schools end up like having to stay in a hotel like a few towns away, like for their rotations. And you don't have to do anything away here if you don't want to, and still get like excellent training and exposure, which I think is a huge value add here.
Thank you.
Jared, Rebecca, if you two want to add anything, feel free.
Yeah, I don't think I hadn't thought about it much coming into it. And I think like what Teresa said is the big thing, that there are different options that you know, you can choose from depending on what you're interested in. So you don't really have to worry about it until that second year when you have a little bit better idea of what you want to do and what kind of experience you're looking for. You can have whatever you need.
Yeah, it wasn't something I put much thought into before the end of second year.
Excellent. Thank you all for that. Alyssa and then Nikita can follow.
Hello, thank you all for all of your insights. My question's pretty similar, but a little bit more specific in terms of like what were the experiences in the first 2 years that swayed your decision to do one of the paths? I think, Ashley, you mentioned that you had talked to the program director. I'm wondering if there are sort of specific things that helped you all make your decision in terms of who you spoke to, or even just exposure in classes or anything like that.
That's a really good question. And it kind of gets into, you know, whether or not we had clinical exposure prior to starting clinical rotations. And as you know, for us, we started in the pandemic, so it was a little bit tricky. I think a lot of people either come into medical school with at least a broad idea of what they want to do, you know, maybe surgery, maybe primary care. But I think as you start learning the material, as you start connecting with mentors and physicians that you meet along the way in medical school, you start to have a better idea of what you want your future to look like. And again, like choosing your pathway for third year and fourth year is not that big of a deal in the long run. All of them are great. All of them are going to be really, you know, beneficial and educational. You're not going to make a wrong decision. But for me, I was in the process of, I had always wanted to do psychiatry, but there was a moment in time whenever I was convinced I was going to do either family med or OBGYN, because those both have areas of interest for me. And at that point, that's kind of when I connected with Dr. Raddick, who directs the Metro Longitudinal program. And he kind of talked about the benefits of being in the outpatient setting, but also the downsides. You don't have as much time in inpatient world. For me, that was fine. I kind of knew early on, I don't really want to spend a lot of time in the hospital, because spending time in the hospital is very different than spending time outpatient talking to patients and helping them with primary care. So you'll kind of get a little bit of a sense of that. And same with, you'll get it in LCSP. You do, I think, that's like a integrated clinical exposure, preclinical clinical exposure. I think you get both hospital and outpatient experience, and from there you can kind of see, you know, what do you like.
Anyone else want to chime in? All right. Well, let's thank you. And Nikita, go ahead. I apologize, I mispronounced your name.
No, it's perfect.
All right.
Yeah. Yeah, this is kind of maybe a more logistical question, but I was wondering like how many acting internships and like electives you can schedule for yourself, and like how people go about doing that, how many people usually take on for themselves, and also like, does it necessarily have to be in a area that you're 100% interested in terms of your specialty, or how does that work? Just because I was like very interested in the like Metro Health like Pride Clinic, and I was thinking like if there might be an elective associated with that. That sounds very appealing to me, but I don't necessarily know if I would pursue the longitudinal track associated with Metro Health.
Yeah, I can try to answer this. First of all, I feel like some of these questions are the same ones I'm trying to answer for myself right now, because we're just kind of now building our fourth year schedules, which is when you kind of have the most flexibility to explore some of these things. But yeah, I think you get, and there also is some time during third year where you can, it's kind of up to you. You can try to do some electives then as well. But I ended up feeling like I wanted that time for like research and other things I needed to do to kind of break up that crazy third year schedule. But yeah, now then looking forward, fourth year kind of gets to be up to you in a lot of ways, which is in some ways overwhelming, but also like exciting, because I think the way I'm doing it. So at least for internal medicine, we're supposed to do 2 acting internships. And then the rest of the year can be a mix of the like clinical and non-clinical electives that I think for the most part can be in whatever you want them to be. There's definitely specific ones I want to take that I think will help me with internal medicine specifically, like infectious diseases, and like maybe like an ICU rotation. But beyond that, like I think I'm going to do an interventional radiology one, which is like not something I'm probably going to do much of in the future. I just think it will be kind of fun to learn about. And yeah, I think there are definitely at least a couple like LGBTQ ones, I think like clinical and non-clinical ones. And then, so yeah, I think that can definitely be something you can build in for sure. Yeah, I hope that helps. So and you get to do electives at any of the hospitals as well. And there's a huge catalog. And you can even build your own if you're like, I really want to spend more time in that Pride clinic. Like, I can't speak to this personally, but I think that's something that you could definitely set up. So I'll let anyone else add on if they know more about that.
It's really easy to make your own elective. I did it for an acting internship I'm doing right now. All you need is a faculty or preceptor who will work with you, and you like come up with a course description and you submit it. So you can definitely do pretty much whatever you want.
Excellent. Anyone else want to add anything? All right.
Thank you so much. That was really informative.
Thanks, Nikita. Marcus, go ahead. Thanks for waiting.
No, of course. Thanks for putting this on. I just have a question in terms of like the evaluation during your clerkships, and like, is it the same or different across different, clerkship, like whether it's Metro Health or any of the other ones? Like, is the evaluation the same across the board?
I can answer that. So I don't know if there's data, but amongst students and just like conversations among students, there are traditionally what people experience like different level, like severities of grading, depending on what rotations you do. So, and even just the schedules may be different. So I'll give an example. You have pediatrics. You have at University Hospital, you have Rainbow, which is like a, national like pediatrics center. And so they take pediatrics very seriously. And your schedule there has traditionally been known to be like harder than at Metro Health, which still takes care of a pediatric population, but isn't, nationally recognized for pediatric care. So like something like that might be different. And, because of that emphasis, because of that focus, again, there may be differences in how they grade you and, the intensity of the grading. And there's little things like that, again, but just like students kind of pass the information along from year to year, like, oh, okay, if you do a rotation here, you might have more hands-on experience, but, you may not honor, or you might not get that top grade or things like that, or this is a place and this particular doctor has a really good, that writes really good letters. So like maybe you want to go to that program. And I think people for the most part take some of those considerations in if they know they're interested in something. So if you may want to, if you're interested in pediatrics, you might want to do it at UH, Rainbow, than, Metro, for instance. So that's just my opinion.
I had a question about the grading, if no one else has any answers to that question.
I just to say one thing real quick, I think, like, I'm sure some of the things Rebecca's touching on are definitely true. I also think in the end, there aren't huge differences. Like they have us all use this same like clinical assessment system where we submit like requests for feedback. I think more of the differences are like every preceptor, every doctor is going to be a little bit different. They're going to spend more time on feedback, some more or less. You're going to click with some people more or less. Like, but I think generally they'll all probably respond to some of the same, like if you're super engaged, you're working super hard, like there's always going to be some differences, but I think essentially the systems and the things that will allow you to perform well are more or less the same. Like that's my impression, but.
Yeah, that's true. And I also want to add that at Case in particular, our first and second year pass fail, and then we transition into, not pass fail, like we're graded for third and fourth year. So at least for me, and I think for other people too, it is sort of a transition, worrying about these scores and about these grades. And you're also doing the shelf exams and trying to get above a certain score on those. But my best advice is to really, try your hardest to practice wellness in these times, because focusing on, getting honors, getting a certain grade never really works out well. It usually just, you end up like looking a little bit silly sometimes if you're trying a little bit too hard. I don't know, just be genuine, all of that stuff. But in the end, the thing that's nice is that you get qualitative feedback. So you get a written paragraph about you. So that's where you really get to explain your strengths, even if somebody didn't get, clinical honors, but they still got, commendable or whatever, and nice things are written about them, great things are written, but whatever, they didn't turn in an assignment or something like that. You get to explain those things. And I think that's really important. So I think if you're trying to get the most out of rotations, you will be really focusing on making connections and building relationships with the residents and with your preceptors, because that's how they're going to write the best qualitative feedback. And that's how you're going to really get the most out of, learning and going forward for your residency applications.
I think part of the adjustment to third year is just adjusting to the fact that for the first time, everyone's going to have a pretty heterogeneous experience, just depending on your site, depending on like week to week or residencies or what service you're assigned to. So you're always going to have people like with praise for certain things or complaining about certain things. Just take it with a grain of salt. And I think what Ashley said, just like be genuine and be interested and curious and engage with the content, engage with your patients, and just focus on that and less on comparing your experience to others. You'll do fine.
Thank you.
Thank you all. That was really great. Gosh, thank you all. That was great. I want to ask a little bit, just, you're all third years getting ready to start your fourth year here in the near future. Like talk about some feedback you've received or just maybe like ways you've received feedback, probably a better way to say it. Like in terms of what are some ways you've received feedback and like, okay, I've learned a lot, and here's how I've been able to learn that from this individual, that individual. Is there a kind of a whole evaluation process after my first, second, third rotation that I've been able to gather that and learn from that, and maybe just talk about some of that, where those growth opportunities lie. And then we'll get to your question next, Dina.
It's kind of an add-on to that.
Oh, go ahead, ask it then. That sounds good. I like add-ons.
Yeah, so that they can talk about it while they're talking about this.
Good, I like it.
Are your different preceptors, are they good about giving you feedback at the beginning of your rotation so that you can improve and get those better grades and feel like you know what they're looking for? Or does that just vary hugely depending on who you're with? And is there something that you found that you can do at the beginning to encourage them to do that? Thanks, Tom, for letting me.
Thank
jump
you.
in.
Feel free, whoever wants to start.
I can. Oh, sorry, Rebecca. Okay, we'll go to you. I'll go to you next. Yeah. So I think. Okay, so I think one of the ways that I received feedback that really helped me, that initially didn't feel amazing, was like when I was like when my preceptor would be like, "Oh, did you look at this in the chart? Like, did you ask them this question?" Like, and then I'm like, "Wait, no, I didn't do those things." And then then that drills into your brain, like, okay, for next time, I'll make sure to do those. And so now at this point in the year, it's like second nature to like look at the updated labs or like do some chart review. So that's one way that they gave me feedback that, yeah, again, I was like, oh no, I messed up, but actually like they're just trying to help you get better. I think sometimes also like you kind of have to ask for feedback, because these doctors are of course very busy and they're just trying to take care of patients and do their job. And like, you think they're like hyper focused on you, but like really they're not. Like, so you kind of have to sometimes speak up and ask them for what you want or need. And like even though it can be a little nerve-wracking, being like, oh, do you have any feedback for me, like after that presentation, or so I think asking for feedback. And then we do submit these like electronic requests for feedback, and some of them fill out those forms very quickly. Some of them, it must get lost in their inbox somewhere, and they're, it can take a little bit of follow-up to request some of that. So yeah, so I think the ones who are like, you're going to get a mix of ones who are like very teaching focused and like offer up more of that feedback. For other preceptors, you might have to ask for it a little bit more. Yeah, Rebecca, do you want to add on to that?
Yeah, I agree with everything Teresa said. Another thing built in structurally is every rotation has a mid-rotation feedback opportunity. So with that, some differences is, I know like on my surgery rotation, we had a form that we had to sit down with a resident or attending and fill out, and they had to give us feedback, and then we presented that, and also like a self-assessment of how we're doing during that mid-rotation meeting. Not every rotation has that like mandatory form that needs to be discussed, but the mid-rotation is sort of like a natural stopping point for all of the rotations where you're like, oh, how am I doing? And then like kind of Teresa was saying, depending on your preceptor and all of those types of things, you may have already be given feedback, but if you haven't yet and you're feeling like you want it, no one's gonna like chastise you for asking for feedback, or they shouldn't, I should say. They shouldn't chastise you for asking for feedback at that point. And it's a good opportunity to say, okay, where am I and how do I want to finish like this last half of my rotation? Some rotations are a lot, even like week to week, you might be on different services. So that's another thing to consider. Usually, midweek, Wednesday is a good time if you're like switching a specialty to say, okay, how would I do this week? And like maybe try to turn things around Thursday and Friday. If that's the case. And then there's also some preceptors that are just really good. Like I've had, particularly from my experience, preceptors in the OR who will give you feedback like immediately, like, oh, your suturing was good, but you could do this better. But again, that's like individual differences.
Getting feedback during third year is really, it's so important, and it's really scary, and it's great. It's just like, it's a lot. And it is true what everyone said. Every preceptor is really independent. And I just wanted to quickly say, the most important thing to keep in mind is that all of these, they're humans, like they're physicians, they're people. In some cases, especially in high stress rotation, surgery, OB/GYN, that sort of thing, people are stressed, and the feedback might be more reflective of their stress than your actual performance. So always keep that in mind. But yeah, I think it is really important to start by establishing communication, saying, I would want feedback. And then of course, if you're someone like me who doesn't like asking for feedback or like bothering people about that, you can be very intentional about it and have a plan before you go in, and usually it works out well. And it is a good practice in interacting in kind of like awkward situations with people. But yeah, don't be afraid to ask for feedback. It's really important. And don't beat yourself up too much if you don't get the best feedback. Just remember that, everyone's in that situation, everyone's learning, everyone's growing. So yeah, it's just part of it.
I think as far as like getting feedback early on, you can make it easy for them to give you feedback and like ask very specific questions, like on the fly, like, oh, did I do that exam? Okay, like, was there anything else that you would have asked this patient? And like asking pointed questions that the residents or attendees can like directly focus on. You can learn a lot. And that also shows that you're trying to learn, and that looks really good for their long-term feedback, that the student asked for feedback throughout and improved on this, and this.
Thank you all so much. Appreciate it.
Thank you. I want to ask a common question we seem to get that hasn't been brought up yet about research. And are you able to, first of all, do research? Say you're like Teresa, you're in the Cleveland Clinic longitudinal clerkship, and Ashley, you're doing all your training at Metro. Say you have a research mentor that you meet that trains at university hospitals or trains at a hospital that you haven't been able to have the opportunity to train at yet, or chose not to train at, I guess, so to speak. How does that work? Is that still possible? I guess, yeah, anyone want to speak just on behalf of that?
Tom, are you, sorry, could you clarify that? Are you asking?
Is it possible? I guess is my question. I'm sorry. Yeah.
Yeah, I can just quickly say that that's what I'm doing right now. Like I'm working on a project with a preceptor at UH, and for me, it has more to do with time. The challenges have more to do with time than location in a lot of ways. Like just,
Sure.
but we do have those built-in like blocks of like, depending on which track and your schedule, like I've had 2 like 3 to 4 week chunks of time during the year that I can use to like make some progress on those projects and make my way over to UH to work on it. Or like Friday afternoon this week we have off, so I'm going to go over to UH then to work on it for a bit. So it definitely is possible.
Excellent. Thanks for that, Teresa. If anyone has other questions they want to drop in the chat too, or we have about 5 minutes left, feel free. Rebecca, do you have to say something? Go ahead.
Yeah, I just want to add on to the research, like extracurriculars during third year. It is definitely a challenging time. And at this time, your clinical experience is your priority, but it definitely is possible. And kind of adding to that is not only like conducting the research, but there are opportunities to go to conferences during your third year. Just being mindful of like time management, being professional about making sure your rotation knows about these things. And I've been to several conferences throughout third year and have yet to have someone, for me at least, be upset that I went, or it be reflected on my grade, or like penalized for wanting to go to a conference. At the end of the day, like the point of being in medical school is that you're learning, and a conference is an opportunity to learn. So don't be afraid to like seek out any opportunities to learn throughout medical school, even if it may sometimes conflict with something else.
Excellent. Thank you for that, Rebecca.
Yeah, I have another. So on that, Rebecca, how did you work with, like, did anybody say, okay, that's fine, but you're going to work, extra to make up for it? Or how does that work?
I think we all do across the sites, but I'll speak for at least traditional. Most of the rotations, you get 3 days of absences for each rotation. So that's just in general. So a lot of the times I was just very strategic about making sure that I just only missed 3 days. But there actually have been times, like for instance, right now I was just at a conference, went to a conference next week. So in total, I'm missing like 4 days. And they were like, that's fine. But on another hand, I think internal medicine, I missed like maybe 7 days in total throughout like the 12 weeks or whatever. And I did like 2 weeks over winter break. 2 weeks, I'm so sorry, 2 days over winter break to like make up for it. So it's a mixture, but they work it out with you. They work with you to like meet your goals. And
Cool. And how did you find out about the conferences? Is that through a mentor that you're working with, or research that you're doing with somebody? Or did you just say, hey, this looks cool, I want to go? And are there travel funds available for that, or is that all your own?
Yeah, so a little bit of mixture of both. This is like a intense research talk, but it's a little bit of both. Sometimes you see conferences on your own and your mentor is willing to support you. If you're like, oh, we are working on this project and I want to present at this. Sometimes you have projects that the research team already knows they want to present at, and everything in between. So that's one thing. In terms of funding, I think our school actually just started this year. Everyone gets can apply once for $500, I believe. Correct me if I'm wrong, but I believe we all have like a graduate fund now we can apply to once for a conference. And then there's also, again, affinity groups, things like that you may be able to seek funding from. And sometimes your your preceptor or the department that you're doing the research in has extra funding. So again, if you're like, hey, do you mind, helping me out with this? I think most of the time will try to help you figure it out.
Thank you.
Excellent. Well, we have about a minute left here. So I just have one last question in the traditional core of Rebecca and Jared. When you're training at multiple hospitals, Metro, UH, the VA, are you like, say I want to do OBGYN and pediatrics at university hospitals, and I'll take psychiatry and oncology at the VA, or however it's structured. Do you just like submit preferences, and then if you don't get your first choice, like you can trade with someone, and since there's so many students doing the traditional core generally, you can usually switch with somebody? I know we have a minute left, so if you want to do a quick rapid fire on that one.
Yeah, you submit preferences, and then I think if you have a specific reason to go to a certain site, they'll do their best to accommodate that. Like
Okay.
I wanted to do psychiatry at Metro because I want to work with like safety net population. And then if you don't get it, you can trade with others.
Okay, excellent. Thank you for that. So I want to say thank you, everybody. This has been very, very insightful. I always feel like I learn things when I watch these student panels and watch our students. So I just want to say thank you. Thank you, Teresa. Thank you, Rebecca. Thank you, Ashley. Thank you, Jared. You were fantastic. This is the second part of the panel experience. So you'll have one last experience here. Yeah, it'll be a 5-minute break. So it'll be 2:45. Or 2:40.
For whoever was in the
recording, and we'll go ahead and get started. So this is the M3, M4 panel, all about life on the wards and being an M3 and M4 student. And I have some fabulous panel members with us. I have Alex Hill. Hello, Alex. We have Ian Dorney. We have Emily Manning, and we have Alex Soon. So just want to say thank you all for being here. I'm going to have each of our panelists just introduce themselves first off to start. Let's go with just name, hometown, how you structured your training. So I did the traditional core, I did the Cleveland Clinic longitudinal clerkship, or I did the Metro clerkship, and the specialty of interest that you are looking to apply to, or perhaps that you have matched to if you're an M4. So name, hometown, how I structured my training, and where I am interested in applying for match in my specialty, or where I've already matched. Alex, I'll start with you.
All right. Yeah. Hi, everyone. I'm Alex. So I'm originally from Columbus, Ohio, so not far from Cleveland. I did the traditional pathway. So I did the rotations at Metro, university hospitals, and the VA. And I'm a 4th year, so I have already matched. So I am going to Chicago next year, and I'm going to be doing urology at Rush University.
Excellent. Thank you, Alex. Let's go to Ian next. Ian Dorney.
Hello, everyone. My name's Ian. I'm a 3rd year. I am from Seattle, Washington, so I moved from the West Coast. I did the traditional track as well, which is Metro, UH, and VA hospitals, and then I'm applying into psychiatry here in a few months.
Wonderful. Emily Manning. Go ahead, Emily.
Hi, everyone. I'm Emily. I'm an M3 and I'm originally from Florida, but I lived in North Carolina for 6 years, and I chose the Cleveland Clinic track. I'm applying into IM with hopefully a pursuit going into cardiology.
All right. Thank you. And Alex Soon. Go ahead, Alec.
Yeah, sorry, I'm a little late.
Oh, we just got started.
What do I need to say?
Oh, I'm so sorry. Yeah. Name, hometown, how you structured your training. So I did traditional longitudinal clerkship at Cleveland Clinic or Metro, and the specialty you will be applying to, or your specialty interest if you're not sure yet.
Yeah, gotcha. So, hey everyone, I'm Alec. I'm a 3rd year from Kennewick, Washington. And I chose the Cleveland Clinic track. And I'm going to be applying urology.
Excellent. Well, thank you. Thank you. I want to just start out and ask all of you, tell us a little bit about, I guess, Alec, and I'll start with you kind of just, and Emily too. So why the Cleveland Clinic? How has it been doing all of your training at the Cleveland Clinic? And talk about what led to you making that choice and how it has been so far, or how it has, how it's gone, and what you expected, what you didn't expect, and kind of what went into some of that that decision?
Emily, you want to go first or second?
I don't care, whatever you prefer.
No, sorry.
Yeah, yeah, so I think even before starting third year, like when deciding which track to select, I had heard a couple things from older students that I think are largely true, which is like, as sort of a extra shiny name brand hospital that is like the Cleveland Clinic kind of has some extra hoops to jump through for stuff and a little more admin type of things to deal with sometimes, which can be annoying sometimes. That's like maybe one con. And then it's nice because sort of everything is very integrated into one system, and it's using Epic, which I think is going to be less of an issue now that UH is transitioning to Epic as well. But for me, I was fairly sure that I wanted to apply urology, and the Cleveland Clinic is like the best program in the country. So I felt like I could try to use the opportunity to build additional like connections with faculty and stuff like that while I was there. Yeah, I mean, you're going to a lot of different sites regardless of which track you're on. So like, even though I've spent maybe 70 at least percent, maybe 80% of my time like at Cleveland Clinic main campus. I'm on this right now. I don't know why I showed that, it's blurred. But you get to, go to remote sites for like family medicine, outpatient stuff, or like inpatient psychiatry at a different location as well. So I think regardless of the track, you get multiple sites and you will get like a large academic center experience. But yeah, I will say at the Cleveland Clinic track, you're rotating also with some of the Cleveland Clinic Learner College of Medicine students. I haven't had any issues or anything like that. They're all lovely people.
Excellent. And yeah, Emily, if you want to talk about your decision too.
Yeah. So let me start this off by saying that you cannot choose wrong. Like, they tell you that within your second year when you choose, but like every single hospital system that you rotate through here is phenomenal. I think that's what makes Case such a great school to come to medical school for. Because generally at every hospital system I've been at, I've had a great experience, just different experiences. For me personally, I knew I wanted to do either cardiology or urology. And like Alec was saying, like Cleveland Clinic is one of the best hospitals in the country for both of those things, right? So that's kind of what drew me to that appeal. Another thing that I kind of wanted out of my training personally is the cool thing about Cleveland Clinic is you see a lot of zebras. You'll hear the term horses and zebras in medicine, and horses is kind of like your bread and butter, like the things you see and do every single day of your training, whereas your zebras are those like big mystery cases, like people who have been getting worked up for like a decade and they have like this super rare condition. And for me in my medical school training, I really wanted to be able to see the zebras because I was like, when in my life am I going to be able to see this level of complexity? And I really liked that about the clinic. And I kind of was like, I don't have as much choice in my residency program, obviously. Like, you can rank and match, but at the end of the day, a big computer is going to tell you where you go. And so I kind of was like, well, I'll get the bread and butter in residency. But I just want to see some really cool cases in the meanwhile. And like I said, you cannot go wrong. I've been at VA, UH, and everything was phenomenal. And I really have had a positive experience at Cleveland Clinic. Everyone there has been very like kind to me, really invested in my education, like taking the time to really like support me as a student learner. So yeah.
Excellent. Thank you for that. And I know we have a couple questions or one question in the chat here. And if anyone else has questions they want to add to the chat, please feel free to do that. Alex and Ian, this will be more for you. How far from campus are some of the more, I guess even for everybody, even some of the more like remote sites? I know Cleveland Clinic, UH, that they have et cetera, have satellite campuses kind of throughout the region. Is there anybody or anywhere you've trained that has been a little more further outside the city? And also Ian and Alex, I just want to ask kind of what led you both to choose the traditional core and train at multiple hospitals as well. So if someone wants to take that first part, and then Alex and Ian, if you want to jump in whenever and share that too.
Sure, yeah, I can go for it here. So to answer that first question, I did my family medicine rotation at a clinical site that was just recently bought by University Hospitals. It was previously Lake Health. And that was out a little bit past Chardon, Ohio. So it was about maybe 40 minutes for me to drive there in the mornings. So I would say, like, when you get to your third year and are doing clinical rotations, I think having a car is pretty important, because you will have rotations that are out a little bit. But for doing that I think I did that for 6 weeks, and it wasn't the end of the world to drive 40 minutes for 6 weeks. Most rotations are going to be within like a 15-minute drive, I would say. And then for what caused me to choose the traditional pathway, I would say I definitely agree with Emily that you really can't go wrong between the two of those. I kind of wanted to get a more broad experience of what you see in medicine. And I kind of felt that through doing the traditional pathway, I could do rotations at university hospitals, which is a big academic center, just kind of what you think of when you think of academic medicine. I could be at Metro, which is a county-run hospital, which certainly has a different patient population that I think it was really important to get exposure to. And then I could also be at the VA and kind of see how the VA side of medicine is run. And kind of see what the pros and cons of all of those are. And I think that really helped me kind of narrow down what I wanted to see when I was interviewing for residency programs, because I kind of had experiences rotating in all of those different hospitals. And then when different residency programs were telling me what hospitals they rotate at and what those clinical sites are, I felt like I had kind of the opportunity to have been at those places before and got a little bit more of a sense of what it would be like to be a resident there. So that was just kind of something that I enjoyed. But yeah, definitely like what Emily said, you really can't go wrong.
Yeah. For me, I think farthest I've had to drive has been like less than 20 minutes, like 15 minutes. 20 minutes is the farthest I've had to drive, and I only have one more rotation left, and they're all at UH Maine. So it's not like a necessary thing that you're gonna have to drive 45 minutes or something, but some people do. Let's see. Otherwise, clinical grading. Yeah, clinical grading's the same. And then why did I choose the traditional track? I did the same. I didn't really know what I wanted to do. I like had a rough idea that I wanted to do like something surgical, but I didn't really know. So I was like, I figured it would be better to get like an experience at different hospitals to try and like sample more things, rather than like try and stay at one hospital. And I didn't like feel super strongly about like academic medicine and things like that. So the traditional track was good for me. Clinical grading is the resident who evaluating you and your evaluators give you feedback. Yes, they do. And it's not like only for the top 5% of your group can get an honors or something. It's not like that. So it's not like super high pressure. Just to answer your question.
Thanks, Ian. That's great. Anyone else want to chime in on grading or any of the other questions in the chat? I know there's a question on clinical grading. I know just in terms of spots, to my understanding, while the Metro clerkship only can take 4 students, they haven't really had a demand for more than like 3 or 4 students. There were only 3 students this past year, so there hasn't ever been like a lottery for that. So no one has been shut out of that, I guess, is the moral of the story. But it is very small. I guess if the data drastically changes from year to year, I guess there could be a lottery for that one. Guess you never know. But I believe someone on the panel last session said there were, I think, just over 60 students in the Cleveland Clinic longitudinal clerkship now, and I think there was a little over 60. So most times you're able to get it. There are occasions where they do have a random lottery if it exceeds, I think, 70 or a certain threshold, but it definitely, most students that are able to apply can get whatever, not even select, I guess, apply/select whatever choice they would like. So but does anyone else want to add anything in terms of, I guess, grading or honors or I guess like there is the grading scale. I know it's honors commendable and I think satisfactory or however the system works. Is that something that I guess is analyzed really closely and I guess also just anybody else, anyone wants to say about grading specifically?
Yeah. Oh, sorry, Alex, did you want to go?
Go for it. Go for it.
Okay. This is what I'd say, because I know there's like a lot of concern about like honoring and your ability to do well, especially with step one being pass fail. The biggest factor in your ability to like honors and do well clinically and so on and so forth is not whether or not you chose UH versus VA versus like Cleveland Clinic. Not at all. It is really team dependent and individual dependent. I generally think that if you put like, if you are a kind person, just like you're just kind to your patients, you care about your patients and you show enthusiasm, 9 times out of 10, you will probably do well enough clinically for your preceptors to be like, you know what, this is a great med student. Like they can do this. Like, and Case really does train you well during your preclinical years to succeed on the wards. So I wouldn't be like super worried about your clinical performance at this stage. In terms of percent honors, I don't think they really tell us that information, but every rotation I've been on, there's no cutoff, right? Like everybody could theoretically get honors in most of my rotations, at least what I've been told from my clerkship directors at Cleveland Clinic. For the shelf scores, you do have to meet a certain minimum. So like, for example, certain shelves require like a score of like an 81% on the shelf to be like considered for honors. But even if you don't get that shelf score, you can still be like clinically like commendable, which means you honored clinically, but you just didn't get the shelf score. So there is a distinction. Grading is the same for all hospitals. Yeah, just do your best and just be kind to your patients and to your team. And I promise you it'll work out.
Thanks for that, Emily. Appreciate you saying that.
Yeah, strong agree to everything Emily said. The factors completely outside of your control are more important than which hospital system you're in. Like if you happen to catch an attending known for not being nice on a particularly bad day, then it doesn't matter what hospital you're at, you know. I mean, I've had almost nothing but positive experiences throughout third year. I think just sort of, I guess, to say it in a different way than Emily, but it's just, yeah, everything she said, I agree with. Yeah, we basically, to honors, you need to meet 2 criteria. One is pass some threshold for the shelf score. I think it's set at like about the historical average of Case students, I think, or something like that. And then you have your clinical impressions of the people you work with, essentially residents, fellows, etc., and attendings, of course, where you basically send them an evaluation with like a patient log of, oh, this is what I did for them. This is how I cared for the patient. Here's what I learned through it. And then they'll like write you feedback for that. Like, oh, you did well with this. You could have improved on that. And I think people tend to overstate how hard it is when you start. Like expectations are a lot lower than I thought going into third year. Like people were impressed that I could like give my really crappy oral presentation at the beginning of third year, or like, oh, I like vividly remember I think like panicking on my first week in cardiology when I like realized 5 minutes before rounds that I like forgot to to percuss the patient's lungs. And I like told my resident that, and he just laughed at me in like a nice way. They were very supportive. But there's a lot of anxiety and panic going into third year, but like people get it. This is your first time in a hospital, you know. But I think I heard from my dean that on average, somewhere around a third or so of the class will both meet the shelf threshold and like get the appropriate feedback for honors level for like per rotation. And so yeah, if you miss the cutoff but still get your honors level feedback, you get commendable with clinical distinction, which is like, so it goes honors, commendable with clinical distinction, then commendable, then I don't know, pass, then fail, or something like that. Yeah, but it's frankly, this is way too early for you guys to be spending like, you know, worrying a lot about.
Thanks, Alex. Ian, you want to add anything?
Yeah, I would just say, I think it was like briefly touched on, but really those evaluations are going to come down to just what resident did you happen to get paired with? What attending did you happen to get paired with? And I did a lot of my rotations at Metro, and Metro has residents from both the Cleveland Clinic and University Hospital that rotate there. So most of the time you're going to get just a random hodgepodge of residents anyway. So as far as selecting which pathway you want to do, I think it's just going to be pretty random.
And just to verify, the clinical grading is the same amongst all 4 different hospitals? Okay. Could we talk a little bit about, okay, I know many of you, Emily, Alec, Ian, getting ready to start your 4th year. I know, Alex, you are a 4th year getting ready to graduate who is matched. Congratulations. Talk a little about like receiving feedback. So like, you know, you're going through your 3rd year and you're receiving feedback. I guess, how does that happen? And have you been able to like take that feedback and make improvements? I guess that's one question we always get. And also, I want to ask about like the shelf exams and like preparing for those. I know there's not really like a block to prepare. You kind of are, you know, you roll with it as you're going. Talk to me a little bit about like that balance and how you're able to kind of manage that as well. If everyone wants to share all of that, go for it. And whoever wants to start can start.
I can go.
Go ahead, Ian. Thanks.
So as far as feedback, so you're going to get, it depends. Each rotation, they sit you down at orientation. They go, this is the feedback that we're going to use for your grade. And this is the feedback that you should try and get for yourself. That's not necessarily for your grade, but it's for you to get better. And so you get both forms of those. You get like cumulative evaluations that you don't see until later, but then you get like these formative feedback, like little things. You have a meeting with your clerkship director in the middle of the rotation to talk about how things are going. And then each attending and resident, you just ask them like, how am I doing? How was my presentation? Things like that. And then attendings will often sit you down and just be like, hey, you know, this week you did great. You should work on this. And everybody knows your knowledge base like sucks because you're just learning everything. So they don't expect that. They just expect you to just be there and yeah, be enthusiastic and things like that. And yeah, just be kind and you'll get good feedback. And then as far as, what was the second part of the question?
Oh, I'm sorry. What was the second part of the question? I asked about feedback and shelf examinations, kind of like preparing for like, I know you don't have like a block to prepare for your shelf exam after you finish your rotation. Yeah, talk a little bit about kind of managing that too.
So you basically, UWorld is your best friend. I mean, you go to work. It's harder. 3rd year is harder than the first 2 years because the first 2 years you only have a couple hours each day that you have to be somewhere, and you have a lot of time to study independently and do structure your own time. But when you're in 3rd year, you're working like a normal job, and then you come home and you study. So it's harder, but like the resources are there. The school, I mean, they provide you with what you need. They give you like a kind of a framework, how to structure your day, things like that. So it's not impossible. It's more challenging, but the like with the preclinical stuff that we've had, I haven't like struggled severely on the shelf exams. I've been doing great on the shelves just with like doing UWorld and going to my rotation. So.
Yeah, I guess I can go next. In terms of feedback, I would say I think the traditional track actually uses paper feedback a little bit more than Cleveland Clinic does. Like our feedback is almost exclusively in person or like through this online portal called CAS. The biggest thing of advice I would give you going into any rotation and any hospital is always ask about expectations and ask about like feedback. You know, background about me, like I'm a first gen, like my parents didn't graduate high school. This is like a world that I have no idea entering, right? So the first thing I do on day one is I'm like, what are expectations? How can I go above and beyond? Like, what do you expect of me as a student? And I think that has honestly been so helpful for me because there are things that like I would never know to do. Like I didn't know you're supposed to like do little mini presentations on the middle awards being like, hey, I prepared a 5-minute talk. Like I had no idea that was a thing. Same thing with expectations. I think if you ask about it and you ask about feedback early on and often, I've gotten really good feedback about asking and being willing to change. And I think it gives you time to like improve. it's also just really helpful for you as a learner. You know, you are, you know, within the early stages of your medical career and your education. So the more feedback, the better. In terms of studying for shelf exams, this is something that I think a lot is a little controversial. I think Alec kind of says it in the chat, like be present. Like I know classmates who are like, you know what, like I need to study for shelf. I'm gonna ask to leave early, or I'm just gonna like peace out and like go to a break room somewhere and do UWorld. I would say don't do that. Like really engaged in your clinical experiences, because I think it does supplement your shelf studying. And I know sometimes it doesn't feel that way, but I think that like by doing it really does help. And then do your UWorld and your Anki when you get home afterwards or on the weekends. And I haven't had any difficulties with shelf exams, so that's my piece of feedback with that.
You haven't had difficulty with shelves? Good for you.
Okay, you know what I mean, Alec. It's okay.
Yeah, I would overall say that honestly, third year is awesome. I'm having a great time. It's why you go to med school, you know. I think the majority of you probably didn't go to med school for the preclinical lectures and for that kind of stuff. You went to learn how to be a doctor and be in the hospital taking care of patients. So that to me is just infinitely better than the preclinical stuff. But it comes at the cost of you still have to study. And if you worked a 14-hour day on general surgery, and then you still have to do 20 UWorld questions and then your Anki, like that sucks a lot. Like enough to take my day from great to this sucks. But that's third year. You are learning and being exposed and being immersed at like a rate that's so much faster than probably ever before in your life. And that's just how it's gonna be. I don't know. I think, you know, the amount of pressure for like getting honors and stuff really does depend on what specialty you're intending to go into. Obviously always try your best and stuff, but even for specialties where it's like very important, it's not like a deal breaker, like for like your application, probably. I mean, I guess I don't know. I haven't matched or applied yet, but that's what I'm telling myself. Do M3s have to take call? Yes. It depends on the rotation. I know I think generally, yeah, that one actually depends on probably the hospital and the team even specifically. It's variable. Like on cardiology and internal medicine, I had evening call every 4 days, where in theory it was from like 5 p.m. when the day ends to 10 p.m. In reality, it was stay as long until a patient shows up that you need to admit, work them up, and then go home. But I mean, sometimes there's yeah, I don't know. It really just varies on which rotation.
Yeah, I would definitely agree with what everyone has said so far. And yeah, I mean, I just think that when it comes to call, like there's technically a rule that you can't work more than 80 hours in a week because that's what the rule is for residents. I don't know if you guys have a different experience. I can't think of a time I ever even got remotely close to 80 hours in a week. The vast majority of the time you're going to be with residents that even if your schedule is such that you have to be there until 11 p.m. or whatever it may be, they're going to find an opportunity to get you out of there because they're cognizant of the fact that you need to study for shelf exams. And I think that that's probably something that happens at a lot of different schools around the country as well. I think when it comes to the third year experience at Case Western, it's just very similar to what a lot of other schools are going to offer as well, where you're going to be in the hospital for a long period of time, and then you're going to have to study for shelf exams when you get home. And I think you're going to have some of the best days of medical school are going to be during third year, and then some of the worst days of medical school are going to be during third year. And I think that that's just a pretty universal experience from talking to my classmates here and then friends that I have at other schools. And what's the question? It feels like there isn't much time between step 2 and residency applications. So have you all gauged if you'd be competitive to apply for respective fields? Yeah, so that's a really interesting question. So I will say that as a fourth year this year, I'm the last class that took step one for a score. So my experience is a little bit different than the other three panelists today. For me, I would say that the advice that I always kind of got is you have to treat your application like you're going for the most competitive thing that you can. So you kind of study as hard as you can for step one and step two, do as much research as you can in whatever that competitive specialty is, whether that's ortho or plastics or dermatology or whatever it may be. And then later on, if you decide that you want to go for a less competitive specialty, you're still well prepared to do that. So that's kind of my feelings on that. I don't know if the third years have a different experience because they've kind of played a different game when it comes to their residency applications.
If any of the third years want to comment on that, 'cause I know you all took step one pass fail, right? Emily, Alec, and Ian.
Yeah, I would say, I mean, the whole country is going through this like kind of
That's right.
period of like, we don't really know. And even we asked the residency program directors and they're like, well, step two is probably going to be more important, but we don't really know what we're going to do yet. So it's like, everybody's going through that right now. And I don't think that's like a problem unique to Case, but I think how we've kind of dealt with that is obviously like doing the things you can control before that application to like make yourself competitive. So like research, like Alex was saying, like I thought I wanted to do ENT. So the first couple of years I did all this ENT related stuff. And then as I gone through third year, I'm like, no, I actually don't like this. I've never actually been in the hospital doing this. So I'm kind of switching and using what I learned in doing that to do psychiatry related things. So like, you just do what you can control and we just make the best of it. We don't really know. They think step two is going to be more important and maybe people will have to switch if they don't do as well in step two and they want to do ortho, but I don't think that's like a problem unique to Case. We get like a month off to study for step two and they're moving our clerkships back so we get more time after the clerkships to study, like, and they're doing that like pretty quickly. So they're modifying the curriculum so we can do well on that.
Yeah, I think it's something that's important to highlight that Ian just said there is they are modifying the curriculum to make this happen. They even changed our clinical rotations in the middle of third year to give us a little bit more time to study for step two and do away rotations because they thought that that would be something that was important for my class to apply. So I do think that when it comes to that and how that whole landscape is changing around the country, the administration is very aware of that and is trying to do things to make it possible so that students here can still be successful. At the end of the day, like Case Western as a whole is successful when its students match where they want to go and into the specialties they want to go into. So they're definitely trying to find ways to make that happen.
Yeah, and I'll just add, different specialties value different parts of an application quite a lot differently. So yeah, the best thing you can do is control the parts that you have of your application that you have control over. And in theory, if you can, not everyone can do this, worry less about the parts you can't control. I was going to say something else. I got nothing. Head empty.
But that was great, Alec. Thank you. So I want to. Sorry, I'm gonna pick on you, Alex, because you're a fourth year and you've been through the match and you have matched. So again, big congratulations. I'd like if you have time briefly to talk about the like the match process. And I know your match situation was a little bit unique. Just kind of share timeline when you applied, how you're doing now, and kind of how long's your residency going to be, where are you going to be moving, and kind of what's coming up next too.
Sure. Yeah. So let's see. So first off, I am going into urology, and I always thought I wanted to do something surgical. So I looked at a lot of those different fields, and I kind of tried to take that advice that I was talking about earlier, where I thought I wanted to do some sort of surgical specialty. So I tried to get research early, get connected with mentors early, just to prepare for that. So that's kind of something that I've been doing for the last few years. And then as far as when the actual application started, I would say that was probably around the, January, February of my third year. because that's when I really started applying to away rotations, which is, you know, kind of a big deal in these surgical specialties, especially the smaller fields. So for those of you that may not know what that means, you are going to a hospital in sometimes a completely different part of the country, usually for 1 month at a time, and you just do a regular rotation there like you would if you were still in Cleveland. So I actually did a rotation at Rush in Chicago, which is the program that I matched at. And I was able to meet all of their residents, meet all of their faculty, and it was really just a great way to kind of get to know them, and they got to know me as well. So that happened in August is when I did those away rotations. So kind of throughout the summer and then early fall, you're doing rotations, preparing your application, and then that all gets submitted in September. Now, for me, for urology, we do have a little bit of a unique match, like Tom mentioned. So it's actually an early match. And the way that that works is you submit everything in September, and then there's one day in October where all of your interview offers come out on the same day. So I applied to 90 programs, which is about the national average for applying into urology, which I know sounds crazy when you think about the number that you applied to for medical school. But that's what the game is. So I applied to that many programs, and then on that Friday in October, I heard back from 90 programs, whether I got an interview, I didn't get an interview, or I was put on their wait list. So that's all on one day, which I actually really appreciated. I thought that was a great way to do it. And then throughout kind of early October, mostly November, and a little bit of December, I interviewed at the programs that said that they would interview me. For urology, that was all on Zoom this year. So I had a whole setup in my dining room area. You know, I got the ring light, you know, got everything all set up to look pretty, and did interviews for probably 5 or 6 weeks. Is how long that lasted. And then we found out where we matched in early February for urology. Most people found out on St. Patrick's Day, actually, a couple of weeks ago. But for urology, it was an early match, so it was in early February. So since then, I've kind of just been hanging out. I am doing 4th year rotations now, which are much more relaxed than 3rd year rotations. So for 4th year, you can choose whatever you want to do. There's just a certain number of weeks that you have to be on rotation, but you can do anything you want. So I've been doing radiology rotations right now, and I'm going to Metro and just hanging out with the radiology residents for a little bit. They teach me some things, and it's really nice because, you know, I can say I'm going into urology, and they'll find specific studies that they're going over that are urology specific, and they can kind of walk me through those. So it's been really nice to kind of learn things more tailored to what I'm going into. So I actually only have 2 weeks of rotations left, and then I'll officially be done. And let's see, my lease in June, or I'm sorry, my lease in Chicago starts in June. So I'll be going there June 17th, and then things get started for residency. So it definitely all goes super fast. But it's just because you're, you know, bouncing around from rotation to rotation every several weeks. So it goes really fast when you do that. But I've definitely learned a lot over the last couple of years. Does that answer everything, Tom? Any other
That was
questions?
great. Very insightful and thorough. Thanks, Alex, and good luck. I'm going to miss you. Appreciate it.
Thank you, Tom. I appreciate it.
I want to ask a little bit about kind of the acting internships experience as well. I know I don't know if any of 3rd years have done that. Yes, this might be another Alex question. Talk a little bit about what are the acting internships. I know you have a little bit of an authoritative role in those. If you could, anybody could speak upon those, that maybe have to be Alex as well.
Yeah, sure. I can talk about those. So those acting internships are the away rotations that I was talking about. So generally how it works is you'll do acting internships at your home program first. So I did an acting internship at University Hospitals and within their urology department. And then when I did these away rotations, I did 2 of them at 2 different hospitals, and those are considered acting internships as well. And you basically it's what the name sounds like. So you're kind of a little bit below the level of an intern, which is a 1st year resident. And you're kind of managing things in the morning. So I would come in every morning and make the list for the residents before we round. And then usually on the surgical acting internships, you are in the operating room for most of the day. So I'd make the list in the morning, we'd round as a team, and then I would go to the operating room and just kind of cherry pick whatever interesting cases were going on that day, and then just kind of hang out in there and talk to them about the procedure and learn about the procedure, learn about the anatomy. But it was just a really good way to get face time with all of the attendings at these programs, and also a good way to learn a lot about the field that you're going into. You certainly don't have to be super knowledgeable about the field on your first day of your acting internship, but you learn so much because you do 3 or 4 of these throughout the summer, fall of your third year going into fourth year. You can learn a lot in that amount of time. So one of the benefits of Case Western is that you have 2 options where you can do acting internships for a lot of these specialties. So there are a lot of programs around the country that don't even have a urology department, for instance. But at Case Western, we have 2. We have University Hospitals and we have the Cleveland Clinic, which Alec mentioned earlier is probably the top program in the country, depending on who you talk to. So pretty much, as far as I'm aware, I think pretty much every field has at least both of those home programs, which is just so great when it comes to the research that you can get, the letters of rec that you can get from different faculty members there, and just kind of the exposure to the field that you can get even as a first, second, third year medical student. So I think that the level of resource that offers is incredibly valuable.
Excellent. Looks like you have a question in the chat on the topic of acting internships. How does the process of picking a hospital for an acting internship actually work? Do you have to apply?
Oh man, so I bet the third years might be able to answer this because they're going through this right now. So it's an application process called VSLO, which is the bane of my existence. And it's not a Case Western specific thing. It's a national application service. And it's a process. It's a little bit challenging to figure out exactly where you want to go. But basically you apply for this around this time of year and then kind of hear back sometime in the next few months and hope that you get where you want to get into. I guess I'll let some of the third years talk about their experience with that if they have anything they want to add.
Go ahead.
It's not a fun process.
Yeah, I can get started with this because I feel like we should also talk about like the fact that AIs don't necessarily equate to aways. Like Alex said in the chat, it's very different for every specialty. For internal medicine, you actually don't want to do away rotations. It's like, at least for my like program directors and my deans, they've recommended I not do one. It's just not really standard in IM, and it can hurt you more than it can help you sometimes if somebody in the department doesn't vibe with you. Like it takes one attending to kind of take your application in IM. And so general word of advice is do your home programs. Case requires you to do 2 AIs at home. And so generally UH is a lottery system because everyone wants to do a UH AI in IM especially. But like I said, every field is different. There may not be a lottery system for other fields. So sometimes it's a lottery. Sometimes it's like you sign up on the registrar and then you're fine. With Cleveland Clinic, if you're doing an AI there's this mass exodus at like 7:30 a.m. when this login portal starts, and then your computer's going to crash and you're going to fight to get spots in your AI. From firsthand experience, I was like sitting on my couch over there, like, oh my God, panicking. But it works out. And I think that generally, you probably will be fine in getting the AIs that you want at home. Aways are going to be very different. I also want to talk about cost. Not everyone can afford to do an away. And that's okay. Like, I don't want you to ever feel like your application is less than if you don't have the means to afford these things. And there are scholarships and funds available for students who are doing away rotations. But yeah, I just want to put that out there because I know
Thanks
it's
for that,
tough.
Emily. Appreciate that. I guess I want to keep moving on. We only have a few minutes here. Research in any specialty really can benefit you for residency application, even if your research isn't related to your specialty. What about like letters of recommendation for whether research mentor, program director, whatever it is? Yeah, I don't know if anyone wants to address that question in the chat as well. And if you change a specialty after maybe say step 2 and you kind of change your mind, how does that impact kind of that process in terms of finding recommendations in that residency application process?
I think this is once again very specialty specific. I can really only speak to urology because that's what my mind is focused on for residency, which is basically your letters of recommendation. You're expected to get one from each away rotation that you do, plus your home institution and maybe the person you've been doing research with or something like that. And I think different specialties have different expectations for like who it needs to come from. I imagine not every specialty requires the letter to come from someone in that field, although it would be preferable. But like there's like on internal medicine, my one of my attendings was like, let me know if you need a letter or anything from me. I'm sure. And I'm sure that that's a very realistic and viable option that many people take for applying to fields where it, like if it is internal medicine, you know, then perfect. And if not, but they don't require that it has to be from their own field or whatever. That's an option. I mean, it's a good question. Oh, yikes. It's a
So we
good
have a
question
minute
about how
left.
to get the connections. And that's something that I don't think anyone has a great answer.
Yeah, I'm
to.
not sure if anyone has, I don't know if I have any information or data on who matches in their first choice specialty. It really varies from year to year, but I do know, and I think our students can speak from experience, they definitely perform very, very well in the match. Go ahead, Al, did you want to
I
say
was
something?
just going to say on that point, that's not really a piece of data that you're going to get a straight answer on from any school. Every school around the country is going to find some way to kind of cherry pick that stat and make it seem like their match rate is significantly higher than it actually is. So I totally get the desire to know the answer to that question, but just know that like you're really going to struggle to find like a great answer if that's what you're trying to parse out.
We got about 4 seconds. I just want to say, everybody, thank you. Emily,